We don't come into the world alone, so why should we have to go out of the world alone? When we're born, we have multiple family members at our bedside. But what happens when we're actively dying? The physician gives us that diagnosis of terminal illness, which is usually less than 6 months to live. Of course, that can vary depending on each individual's disease process, but most often it's 6 months or less. The dying process is perceived differently by members of the healthcare team, by members of the family, and the patient, him or herself. The dying process is one that should be dignified. We should maintain that they have comfort, they are not in pain. But a lot of times when you're in a setting where you're providing care to that patient, sometimes you don't always have that option to be right there with that patient to see every little time they grimace, every little time that they're restless. So we sometimes have to evaluate our own thoughts and our own beliefs on what should and should not be when a person is actively dying. No one should have to die alone. We all go through these stages of denial, anger, bargaining, acceptance, depression, not in that order, obviously. But Elizabeth Kubler-Ross wrote about these stages. She also had a book entitled On Death and Dying. Her website is the ekrfoundation.org, and it's a valuable website because it provides not only information on taking care of patients that are actively dying, but also we can deal with patients that need hospice, and she gives a lot of resources on that website. SEAL defines providing care, basically that no one should have to die alone, in terms of which is the best setting. Should it be in the home? Should it be in an institution? It all depends on the individual's situation. If they can go home, of course, that's ideal because they're in their own home. They're comfortable there. They can have an agency come in and provide that care at the bedside, as opposed to if they no longer have a home in terms of the elderly. And of course, we're dealing more and more with the elderly population. So a lot of times they don't have their home anymore. They have to be in a nursing home and such, and they have to rely on us to take care of them and to keep them comfortable when they have that poor prognosis. The physician has the role of determining what the disease is, how it progresses, and giving the overall timeline for end-of-life care. The nurse's responsibility is to keep that patient comfortable, to administer pain medications, to ensure that they're positioned frequently. All those situations require a lot more dedication and accountability for that patient at that time when they're actively dying. So a lot of times when we're taking care of patients, first of all, we have to look and make sure that they have that do not resuscitate order, that they've decided that they don't want any heroic measures. The patients, even before they're actively dying, even before they receive that prognosis, a lot of times people will sign advance directives and they'll determine what they do and do not want when they are faced with that situation. The resources that are available for end-of-life care vary depending on each state and possibly each individual city. Hospice agencies are valuable because they provide more eyes on the patient, even in an institution like a nursing home. Nurses are there and they can go and take care of patients, they can administer medication, but honestly they're not going to be at that patient's bedside one-on-one. They're not going to be able to have the time to hold that person's hand except for a few seconds. And it does in every situation, of course, is different, but as a nurse taking care of patients that are actively dying, I want to be there. I want to be able to hold their hand. Unfortunately, time constraints prohibit me from doing that. But when the family is not there, it's sad to have to watch that patient just be alone and no one there to comfort them. So a lot of times we look into hospice agencies, they come in, they provide care, they'll have a CNA that's extra, a nurse's aide come in and provide extra hygiene care, just nail care, just back rubs, anything that will keep the patient more comfortable. The nurses come in, they evaluate medications, they get equipment, specialized equipment for that patient, might be needing an air mattress, something like that. So they provide extra care. They get pain medication in, they change pain medication depending on what kind of pain the patient is having. And then you have the spiritual side of it, where you have chaplains, music therapy comes in, and this is a situation in which my father-in-law, we had him at home, and the chaplain would come in, we had a CNA come in, we had nurses come in into our home, and just help out with the overall care of during that active stage of dying. People work, they have limitations as to what they can and cannot do, so it's very valuable to have someone come in your home and be able to do that. In an institution, it depends on the hospice agency, obviously. I believe a hospice agency should have not only come in just 3 times a week or whatever, but I believe they should have, especially during that imminent dying stage, where the patient, the body system shut down and they're restless, they're in a lot of pain. I believe that they should have someone just sitting there with them, holding their hand, watching for that facial grimacing, watching for those restless signs and symptoms of pain, so that they can report that and get the patient the medication they need for comfort. Berkello 2015 also says too that nobody should die alone. This gentleman that was in the article that I reviewed said that he wasn't able to get there, so he was comforted by the fact that there was someone there at the bedside. And oftentimes I think we do want that. We do want someone there, just sometimes we can't always be there. Another one that I reviewed is Peters 2009, and basically this person said that nobody should die alone, nobody should be in pain. And it is the best situation for us to have someone there when they're actively dying, when they're needing someone at the bedside to monitor that signs and symptoms of pain and keeping them comfortable. Because if that is what the goal is to keep that patient comfortable so that they can move on and die with dignity. Thank you.